It's my pleasure to introduce Dr. Meredith Ronan, who is the co-assistant director of the Comprehensive Training Program in Psychology for UMass Chan and the Worcester Recovery Center, and is also director of psychology at the Worcester Recovery Center Hospital, who will introduce today's speakers.
Hello, everyone. So it's my honor to introduce our two amazing fellows here today. So Dr. Wilkinson graduated with her doctorate in clinical psychology from William James College in Newton, Massachusetts. Prior to her coming to us for a postdoc position, she completed her APA internship at Tewksbury Hospital. Most of her clinical training has been in addiction services, and she completed her second-year practicum at Motivating Youth Recovery, which was an adolescent detoxification and stabilization program in Worcester, and her fourth-year practicum at Worcester Counseling Center under the Health Resources and Services Administration grant, working primarily with individuals with opioid use disorders and co-occurring psychiatric disorders. Dr. Wilkinson is passionate about working in public sector and aspires to continue to work with individuals with serious mental illness in the Department of Mental Health. Dr. Yu earned her doctorate degree in clinical psychology from Long Island University Post and completed her APA internship at Brigham and Women's Hospital. She has received extensive training in the treatment of serious mental illness and has a strong interest in integrating approaches to co-occurring substance use disorders. Some of her clinical training has been at Gracie Square Hospital as a psychology extern, where she worked on a dual diagnosis unit, providing comprehensive care for individuals navigating both mental health disorders and substance use challenges. During her internship, she also completed an addiction elective at Brigham and Women's Addiction Recovery Program, which further deepened her interest in outpatient substance use treatment. Currently, Dr. Yu also participates in clinical work at UMass Memorial Health's ACTS Addictions and Comorbidity Treatment Services, delivering both individual and group therapy. Dr. Yu is passionate about serving individuals with serious mental illness, and she aspires to expand the integration of culturally adapted interventions to enhance the accessibility and effectiveness of mental health care for diverse populations. So welcome.
All right. Hi, everyone. Thank you so much for joining us today. We really appreciate you guys taking the time to come to our Grand Rounds presentation. Today, me and Dr. Yu are going to be presenting on harm reduction model and kind of this general question, are we helping or are we hurting by promoting this intervention? All right, let's get started. All right, so in terms of a financial statement, of course, we have no financial interests or relationships with any research, pharmaceuticals, or any of the tests or the testing companies that we describe in this presentation. In terms of learning objectives, there's a couple of things that I think are going to be important leaving this presentation. So I would like everyone in here to be able to kind of briefly describe the evolution of the harm reduction model, name the core principles of the harm reduction model, and also be able to identify different harm reduction techniques that are used in practice. In terms of an agenda, of course, I'll go through, an introduction, what is harm reduction, really go through the basics of this theoretical model, followed by the history, how we got here, how it came to such importance. And then Dr. Yu will kind of go through some of the implications for treatment, how we got, where we are now, how we can kind of use harm reduction to help improve treatment outcomes with specific studies. And then we'll also speak to the future research. All right, so what do we think about harm reduction? So the harm reduction model has been a controversial topic of conversation since around the 1970s. It's certainly not a new treatment model. However, it does historically have a reputation. So I think it's safe to kind of go ahead and call it out, what may be some of these common assumptions or biases that we experience or start to think about that are associated with this model in particular. So in terms of some of the common misconceptions, the first being, harm reduction is the opposite of recovery. The second being harm reduction is enabling people to keep using. Another common misconception is that harm reduction makes neighborhoods unsafe. And then the last being that harm reduction just plain doesn't work. And because so much of our work as mental health providers is, ensuring the safeties of others and mitigating risk, so, I can appreciate how this model may elicit some apprehension or concern amongst providers, but I do want to kind of talk about the ways in which that this treatment model can be beneficial to the well-being of our patients. So what is harm reduction? So according to the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, harm reduction is a practical and transformative approach that incorporates community-driven public health strategies, including prevention, risk reduction, and health promotion to empower people who use drugs and their families with the choice to live healthy, self-direct, and purposeful lives. So this is the current working definition of harm reduction. Essentially, it's an approach that was developed to help providers meet individuals where they are at in relation to their recovery and motivation to change. It includes policies, programs, and practices that aim to reduce the adverse health, social, and economic consequences of both legal and illegal drug use without the main goal of eliminating consumption overall. So in terms of the evolution of the harm reduction model, I think it is important to kind of look at the history of it. And initially, this model was developed to help reduce the spread of infectious diseases. And as time has evolved, harm reduction techniques have been adapted to reduce all sorts of different maladaptive behaviors. So kind of going back to 1965, Vincent Dole and Marie Neiswander were pioneer figures in the treatment of heroin addiction. And in this year, they developed a groundbreaking approach to treat addiction using methadone, which is a pretty well-known medication-assisted treatment that I'm sure you guys are mostly familiar with. And it's a synthetic opioid agonist. So this is kind of the start of some of that research that started to come out regarding medication-assisted treatments. In 1970, this is when President Richard Nixon signed the Controlled Substances Act into law, and this established federal U.S. drug policy under which the manufacture, the importation, possession, use, and distribution of certain substances became regulated. So the CSA really started to kind of outline and more define substances and what those would be assumed of. So they outlined 5 different schedules used to classify substances based on 1, their medical application, and then also 2, potential for abuse. So to give an example, Schedule 1 would include the most dangerous or the highly addictive substances such as heroin, followed by and trickled down to Schedule 5, including drugs with very little addictive properties. Then we're going to jump forward to June of 1971 when Nixon officially declared the war on drugs. So this stated that drug abuse was public enemy number 1. So, this rise in recreational drug use in the 1960s really led Nixon to target certain classes of substances. And as part of this initiative, Nixon increased federal funding for drug control agencies and proposed more strict measures such as mandatory prison sentencing for drug crimes. And this was followed by the creation of the DEA in 1973. Fast forward to 1982, the CDC. This is when we first started kind of publishing findings on HIV, identifying that the virus, was caused by an infectious agent and not a genetic defect. And this was also followed by the development of the first HIV blood test. Subsequently, in 1983, people who used drugs, who we'll refer to as PWUD, began distributing sterile syringes to limit the transmission of HIV or AIDS. So this was by providing clean syringes. These programs helped to prevent the spread of bloodborne diseases. And since then, these programs have expanded globally, including over 400 syringe programs in the US. So this is going to be one of those harm reduction programs that I will talk to more at length. In 1992, this group, so the first harm reduction working group, was brought together leaders in the syringe exchange to start to address those challenges faced by drug users during HIV and the AIDS pandemic. And this is when harm reduction was initially defined. So they defined it as any positive change as a person defines it for him or herself. And it's aimed to reduce, negative consequences associated with said drug use. A little bit more history. In 1996, this is when social justice activists, really started working with other local harm reduction organizations and departments of health to start the distribution of naloxone, which is an emergency treatment for a reverse opioid overdose. And this was first started in Chicago through the Chicago Recovery Alliance and soon followed by other states and city health agencies such as San Francisco and New Mexico. 1998, this is when the syringe exchange programs really started to expand. In 2002, this was followed by the distribution of buprenorphine. In the 2010s, this is kind of when we really started to see a positive shift in society. So starting in 2015, Obama lifted the federal ban against funding harm reduction programs, really allowing organizations to promote harm reduction more freely and more legally. In 2019, there was a major increase in syringe programs and also an overall decrease in the opioid mortality rates from what we see in research. Unfortunately, 2020 came around, and as we all remember probably very vividly, there was the start of, the COVID-19 pandemic. And as expected, there was a significant increase in terms of substance use and overdose rates. But as time has progressed, there have been some administration-wise and program-wise things that we've done to kind of alleviate some of that. So for example, in 2021, the Biden-Harris administration identified harm reduction as a federal drug policy priority, really allowing people to kind of, expand more funding and expand more time and energy into creating more accessible programs for this population. And then lastly, I'll talk about the U.S. Department of Health and Human Services and their developments to kind of address the overdose public health emergency. And they made many efforts to, advance the research and the demonstrations of harm reduction approaches. They really tried to put more emphasis on promoting evidence-based harm reduction services, expand sustainability funding strategies, and also develop more educational materials and programs to decrease the stigma associated. All right, so before we take a deeper dive into the model itself, I do want to, reorient us to Prochaska and DiClemente's trans-theoretical model. This is also known as the stages of change. So this is kind of a critical component that helps to inform our decision-making when weighing treatment options, especially for folks with substance use disorders. And, in identifying the stage of change an individual is in, this kind of helps us to gain a deeper understanding of the person's sense of awareness, their insight, judgment, and also motivation to elicit change. So let's say, someone who is kind of entering that contemplative preparation stage, they might be motivated to, reduce their behavior, but maybe they're not motivated to be completely abstinent. So harm reduction would actually allow us to give them useful or helpful ways to use more safely or find ways to effectively reduce their use, which could mitigate, risk for adverse consequences and be able to meet them where they're at, as opposed to kind of forcing a more abstinent approach on them. All right. So when we think about harm reduction model, we want to keep in mind the aims, the pillars, principles, and core practices of harm reduction. So to start with the aims of the harm reduction model, there's this push to positively shape attitudes and beliefs of the individuals we're working with. We want to make sure, that we're working actively towards reducing any stigmatization associated with substance use, generally speaking. And we also want to account for the intersection of drug use and other stigmatized behaviors and people's health. So that intersectionality piece to our work with these folks. We want to ensure the well-being of the community at large, of course. And then most importantly, the main focus of harm reduction model is to save lives or to find ways to mitigate risk. All right. The 6 pillars of harm reduction that I'll briefly go into. So when coming up with harm reduction, the main aspect of it was that the work should be guided by people who use drugs and those who have lived experience of drug use. So that was a really heavy emphasis of this model, and being able to, focus on the development of programs, interventions, policies, while incorporating the views, beliefs, and feedback from people who have actually experienced these things. Of course, all individuals have inherent value and are treated with dignity, respect, and positive regard. We want to take into account that all communities are impacted by systematic harms, and are deeply engaged in this program planning, development, and evaluation. So again, really trying to incorporate these people from the population in the implementation and development of these interventions. Let's see. All aspects of the work should incorporate an awareness of race, class, language, sexual orientation, and gender-based power differentials. All harm reduction services have the lowest requirement of access. So really trying to make these as accessible as humanly possible, trying to make, the likelihood of people being able to gain this information and gain access to these programs and resources as easy. And then all harm reduction services are driven by person-centered positive change in the individual's quality of life. To speak to some of the principles of harm reduction, there's a heavy emphasis in terms of respect and autonomy. So we want to make sure that, this working relationship is fueled by respect and giving people the opportunity to make choices for themselves. So really trying to hone in on making sure that a person feels autonomous and making sure that this relationship feels very equal in terms of, their ability to make their own decisions. Of course, we want to provide support. We want to provide many pathways to well-being. So really trying to be creative, think outside the box in terms of the interventions that we're providing or the information that we're providing. And the idea that, recovery looks different for everyone. So there's not going to be one specific way or, one intervention that we're going to, provide to every single person that's going to work. It should really be based on the person and the context of the situation. Also, proactive acceptance and hospitality. We want to make sure that we're trying to connect people with social supports, whether that be family, community supports, friends, peers, anything of that nature. We know through research, having social supports, having people in your corner is fundamentally beneficial and does help to increase the likelihood of more positive treatment outcomes. And then we also value practice-based evidence and on-the-ground experience. So really, moving through and walking beside our patients when we're working with them using harm reduction, as opposed to kind of this overlooking aspect, right? We want to make sure we're helping them through their struggles. Some other important practices are going to be cultivating relationships, promoting safety, of course, prioritizing listening, and a big one, which is assist, not direct. So again, harm reduction is a non-directive approach. So we want to make sure, we're giving guidance, we're helping them through these situations, but at the end of the day, we're really valuing autonomy and helping them to make their own decisions and what they feel is best fit for them. We want to ensure that we're engaging, so the therapeutic relationship, really focusing on rapport building a sense of trust. And then ultimately, we're all working towards, systems change. So between the policies, the laws that are passed, the interventions and the programs that, we develop, we are trying to, work towards a bigger picture here. And finally, the core practices. So these are kind of those effective methods for harm reduction that reflect community understanding, experience, strengths, and needs. So there's an emphasis on, safer practices, safer settings, which could be, in some states there are safe drug use sites where people can go to certain centers and be supervised to ensure safety and mitigate risk. That would be one example. Safer access to healthcare. I think that's, an overarching goal and something we're constantly thinking about, and how to make healthcare more accessible, how to make it safer for individuals. Of course, safer transitions to care. So really thinking about different levels of care, how to, mitigate the risk of higher levels of treatment, if not completely necessary. And then sustainable work and workforce and field, and then also sustainable infrastructure. So harm reduction is definitely more prevalent than we might think. It is a model that we practice day to day, whether we are conscious of it or not. And here are some other examples or activities or precautions we kind of take day to day that are considered harm reduction. So, we have sunscreen, protects us from skin cancer, right? Seatbelts that would protect us from injury from, an automobile accident. And then we have speed limits, birth control, and of course, cigarette filters, which is a little bit more centered in substance use, where harm reduction model generally comes from. All right. Yeah, sure. For substance use in particular, here are some other harm reduction techniques that might sound most familiar. such as, syringe sites, naloxone and Narcan, medication-assisted treatment services, which I'm happy to discuss a little bit more about later on towards the end, or if anyone has any questions or wants to talk about them. But when we do think about harm reduction as providers, I do want us to think a little bit more outside the box because there are so many creative ways that we can help to mitigate risk for our patient populations. So in terms of like substance-specific harm reduction techniques, for alcohol, of course, we have anti-abuse, which is an MAT service, but there's also some other ways that we can kind of think about alcohol and how to kind of reduce the risk. So we're thinking, creating a safer drinking plan. If someone doesn't intend on being sober, okay, how can we make that experience safer for them? Like, who do we plan to give our keys to? What friend are we going to give them to? Are we going to be carrying condoms if someone is more inclined to be, sexually active when they are under the influence? Drinking tracking. Are we making charts or keeping record of our drinking to, help create a more concrete, tangible view of, what our behavior is looking like? Are we using Uber or Lyft? Are we alternating drinks with water? And then, of course, one important one is obviously to always tell people to seek medical intervention for detox, because with alcohol and benzodiazepines, those are actually two substances that can result in death from withdrawal and detox if not medically intervened. Benzodiazepines, very similar, like I just said. However, there aren't a lot of harm reduction techniques that have been looked at or studied, but one of them being is, do not mix with alcohol. That's a pretty big one. For cannabinoids, we want to make sure people have all the information they need in terms of different strands, so indica versus sativa, how that might affect the body differently, CBD versus THC. I've had patients who have, used cannabis in the past to, help with pain relief or help with anxiety relief. So how can we kind of explain the benefits of CBD versus THC that could sometimes intervene with some of those things as well? For hallucinogens, test strips are available. Some people might want to, identify a trip sitter. If you're in a group and most of you are using, it could be a good idea to have someone that's sober or that's supervising in case anything were to go awry. You want to make sure you're in the right headspace. Of course, using when you're experiencing really high emotions can impact the likelihood of you having a positive experience. You want to use in low stimulus environments. I've recommended that people use indoors as opposed to outside in nature. And then, of course, start low and slow. That's kind of just a basic general rule in terms of harm reduction with all classes of substances. For stimulants, drink lots of water, make sure we're staying hydrated. And then I kind of broke it down into different ways of consuming a substance. So for snorting, there's access to fentanyl strips. I will say this isn't generally recommended for methamphetamine use, but it is good in terms of cocaine, and it usually does pick up on whether or not fentanyl is cut in the substance. Also to use clean straws to crush the substance into fine powder. When injecting, don't share needles, use a tourniquet, use alcohol wipes to clean the skin, prevent any type of infection. And then if there's any syringe service programs in the nearby area, helping people to kind of identify those. And then for smoking, use a Pyrex pipe when possible. Purchasing pipes that do not overheat, using a rubber mouthpiece if sharing pipes, and also cleaning a pipe with a steel wool to get rid of bacteria that might cause infection. And then, of course, opioids. So, keeping Narcan on your person, helping people to learn how to administer Narcan if in case someone in the same space as them has overdosed, using test strips again, MAT services. And then some of these other things are similar to the harm reduction techniques used for stimulants as well. And then, of course, nicotine, have nicotine replacements such as patches and gum, but sometimes nicotine can also be linked to like an oral fixation. So how can we help people reduce their smoking by, incorporating the use of toothpicks or the use of regular gum, things like that. Considering smokeless tobacco products such as chewing tobacco or dip, not to say that these things don't have their own, adverse consequences. However, but it could give a person an opportunity to kind of give their lungs some time. And then, of course, there's other modified tobacco products that contain less levels of toxins, and electric cigarettes that use heat but don't necessarily burn the nicotine, which is linked with less adverse consequences. And now I'll hand it over to Meirong.
Hey, before we go to some research about harm reduction practice, I'm going to really quickly talk about the difference between the abstinence-only model and harm reduction model. So in terms of goal and philosophy, the abstinence-only model is exactly what it sounds like. The goal is to complete elimination of the problematic behavior, and this perspective is often rooted in the moral and religious beliefs and operates under the assumption that the total avoidance is the solution. While harm reduction, on the other hand, takes different stance. It acknowledges that the risky behaviors may continue and focus on reducing the negative consequences, and the priority is the safety and well-being of the individual. So talking about in terms of treatment, the abstinence-only model follows a more strict and rule-based structure, and success is often measured by total abstinence, and participants are expected to avoid the behavior entirely. While for the harm reduction model, it provides tools and strategies to minimize harm, and even if they continue engaging the behavior, and they're not viewed as, they're viewed without judgment and no pressure to eliminate that behavior. And in terms of effectiveness, if for those who can fully commit to the structure, the guidelines, the rules, abstinence-only model can work quite well. However, it also has a higher dropout rate, and relapse is common, especially among those who are struggling with rigid guidelines. And it also engaged, and that's why it engaged a narrow range of individuals. On the other hand, harm reduction model, because it focused more on reducing the harm, so it engages broader range of individuals, and it brings more sustainable and result in long term, and it also reduce the stigma, making individuals more likely to seek help. Okay, so we want to show some stats. So globally, 19% or 3 million out of 6 million people who inject drugs, we call them PWID, are living with HIV. But if we look at different countries, so for countries who have good response to harm reduction approaches like Australia, the number of people PWID living with HIV are 1.5%. If we look at countries that have a slower response to harm reduction practice like Indonesia, the number increased to 50%. And for the United States, which endorses a rudimentary harm reduction practice, the number is 9%. Now we're going to look into the research. So we're going to pass along some quotes that we get from this research. And we found these quotes very touching to us. And that's why we include 3 qualitative studies today when we talk about research, because while understanding how the effectiveness of harm reduction process in large scale is important, we also think the listening to lived experience of people who have experience with substance and different kind of treatment provides an enriched perspective and insights into how we can better provide intervention for each individual. Okay, so first question we want to ask is how harm reduction practice is doing at macro and micro level. So, but each state in the United States have their own unique landscape and their different practice and approach to harm reduction. This study, the first study I want to talk about was conducted in Texas. So Texas has a vast geography spanning rural, urban, and tribal community, which make implementing harm reduction practice demanding a lot of economic and staffing resources. And also, Texas is one of the 11 states that still where stringent service programs are legal. So this study is trying to understand harm reduction through the eyes of the 3 most affected group, which are people who use drugs, PWD, harm reductionists, and emergency responders. So they conducted in-depth interviews with 69 participants in total and generate some general themes that review the strengths of the current harm reduction process in Texas, including that Texas harm reductionists, they have a lot of passion and commitment to the work and the people they serve, and they were able to build a strong trust with PWDs, and they're always usually the first group that's respond to them. And also there's a lot of collaborations among like local organizations like mental health authorities, faith-based groups, and community-wide boards, and efforts are underway to establish a Texas-based drug users union, which is collective that will empower PWD to advocate for their rights, safety, and access to harm reduction services. However, they also talked about some barriers that PWD faced with to engaging harm reduction services. For example, many PWD talked about they avoid calling the emergency help because the risk of being arrested when drugs are present at the scene, and the lack of a comprehensive good Samaritan law worsens this fear, leaving many overdose untreated and unreported. PWD also talked about they frequently encounter bias and mistreatment in medical settings, leading to delayed or denied care. Many are not given the proper referrals when they seek medical help. And the dominance of abstinence-only model in Texas also makes it challenging for providers to engage with harm reduction approaches. So if you look at the sheet we just hand out, there is a quote from a PWD participant saying, like, I had a rake stuck in my foot for 8 hours, and doctor came in and said, well, maybe if you didn't use drugs, we'd be able to give you something for your pains. And another barrier they found is that there's current gap in funding and access to services for those various harm reduction organizations in terms of expanding services, conduct outreach, and tracking the overdose-related data. And these gaps disproportionately affect the underserved groups, like racial minority, gender minorities, and rural communities. So studies suggest that to strengthen the harm reduction efforts, it's important to expand the legal protections for PWD and ensure that harm reduction programs have the enough resources that they needed to scale and sustain their services. And it's important also to educate and enhance awareness of practitioners in the healthcare and law enforcement systems to reduce misinformation and stigma about harm reduction. And it's important to center people with the lived experience in shaping harm reduction policies and programs. So next study, we want to talk more about, it speaks more about the challenges in working with individuals with substance use disorder, the importance of planning treatment based on the stages of change, and the importance of having meaningful conversation about drug use with patients. So this study examines the perception of the hospitalized patients with opioid use disorder regarding the integration of harm reduction practices into the hospital care. And they conducted semi-structured interviews with 21 patients and generate 3 themes: the applicability and acceptability of harm reduction practice to oneself, to others, and the perceptions of harm reduction conversations. So when you look into those themes, participants had different levels of familiarity and willingness to adopt harm reduction strategies personally. Some embraced the practices, while others saw harm reduction as unnecessary. Some with limited understanding of the variety of the harm reduction approaches and only perceive that harm reduction applies to people who, only to people who inject drugs. And many will not feel comfortable and open to accept harm reduction supplies that they view as their own use, like syringe programs, compared to those harm reduction approaches that they viewed as other use, like Narcan. They feel more comfortable. Some participants talk about if they are willing to, they're open to carry Narcan with them. So if any other people in need, they can help. And also they talked about limited discussions about harm reduction with their healthcare providers. While some of them really welcome such conversations, they have hesitations due to a stigma, particularly for those with abstinence goals. They talked about they have fears if they set up the abstinence goals but also ask about harm reduction information, how they will be viewed by their providers. And so the studies really underscores the need for a patient-centered harm reduction approaches in hospital that tailored to the individual needs and their goals and their specific situations. The interventions, even for those who are quite open to the harm reduction interventions must be framed appropriately to avoid reinforcing any stigma or discouraging engagement. Okay. So the next, so until this point, a lot of things we talked about the harm reduction is in the context of substance use, but we also want to explore what else can harm reduction be used for. So we want to talk about non-suicidal self-injury. It is the deliberate self-inflicted damage of body tissue that occurs in absence of suicidal intent. The direct forms of self-harm are including cutting, burning, self-hitting, hand bending, and indirect forms include disorder eating, substance abuse, staying in abusive relationships, and reckless behaviors. And it's most common among adolescents and young adults. Here is a DSM-5 criterion for non-suicidal self-injurious behavior. So a couple of things we want to point out first is before the person engage in the self-injurious behavior, there's usually some emotional cues, some emotional stimuli. It could either like negative feelings or thoughts about self-injurious behaviors. And after people engage in the self-injurious behaviors, they always anticipate some following consequences, like to reduce the distress, to increase the positive mood state, or to resolve the interpersonal problems. And the behavior should be viewed in the context of culture and religious. So some commonly used harm reduction strategies for self-injurious behaviors include less damaging tools like sterile razors to reduce infections, wound care education, provide anatomical information to avoid high-risk areas, use elastic band that applies the deep pressure but not the harm, or scratching alternatives. So the last study we want to talk about is a study conducted to investigate the perceived usefulness of harm reduction techniques for adolescents who self-harm. And the interview was conducted on 11 adolescents, and they generate three main themes, which is controlling uncontrollable, barriers to practicing safer self-harm, and developing a broad repertoire of harm reduction techniques, which we'll go into right away. Okay, so many adolescents talked about, so there's mixed views about harm reduction approaches. Many adolescents talked about harm reduction helped them to gain a sense of control and mastery through allowing them to self-harm in a safer way. And most times, one of the reasons why they engage in self-injurious behavior is to regulate emotion, is to increase the sense of mastery. And teaching wound care procedures were viewed as very important by all of them, particularly for those who want to hide their self-harm behaviors. And teaching adolescents the alternate ways to harm, as well as providing anatomical information, was seen as help them to increase ability to choose the extent of harm done to themselves and to care for themselves properly. Following the self-harm actually help them build more sense of compassion. And some also mentioned that it helped build it helps them to reduce long-term damages and frequencies of self-harm by becoming more mindful of the harms these behavior could cause to them. On the other side, some participants expressed anxieties about providing vulnerable adolescents with anatomical information. While they learn harm reduction, on the other side, they may also learn how to harm themselves more seriously, which possibly encourage future suicidal attempts. Others also mentioned that the effects of the harm reduction approaches tend to be short-lived and potentially lead to more extreme craving for self-harm sometimes. And it is difficult to use these strategies. It's difficult to use the strategies when they are in a strong design of self-harm in the moment. Lastly, many participants also expressed that it could be really helpful to broaden the repertoire of harm reduction techniques, including more like destruction-based techniques. Some adolescents personalized want to show, if you look at the handout, last quote on the other side of the paper, one adolescent reported that he draw on his skin a butterfly, so that when he want to self-harm, he would stop because it feels like he was killing a butterfly. He didn't want to harm a living animal. He also reported sometimes writing the name of a loved one, someone close to him, helped reducing the cutting as well. So we saw that was super interesting and something definitely we want to like add to our own like clinical toolkits of steps. Okay. So inclusion of the treatment implications of this research is that harm reduction model emphasizes the autonomy and empowerment, is non-judgmental, education-focused, and directive treatment approach, which is person-centered, and the aim is to reduce stigma at the same time. And it's shown to be effective in reducing long-term negative outcomes associated with the problematic behaviors. The other side, there are some ethical considerations. How do we monitor risk? How do we assess risk? How do we clarify the liability and legal responsibilities? And there are also limitations to the mechanics of harm reduction approaches, like the lack of accessibility and the feasibility of programs, funding, resources, supplies, and also how can we improve the training and education of harm reduction techniques. So that says we definitely need more research. So we think it's really, it will be really helpful if we can develop more harm research and explore how we can develop more harm reduction education or intervention while we're hoping for the recovery, but also acknowledging the complexity of substance use and the possibility of return to use. We can start with educating clinicians about the continuum of interventions for drug use, and research can be conducted trying to create a guide for the harm reduction conversations, how to hold those conversations with a patient, how to make it both effective and affirming and patient-centered. And also further studies to investigate what are the best strategies to apply to different patient populations. And also for the people with non-suicidal self-injurious behavior, here are some ideas about future research. More research definitely need to support the development of guidance about how to hold more research are required for us to understand lived experience of people who had the experience with self-injurious behaviors and how to include these into our study. And also we are thinking about maybe including more advertisement on the social media, and those web-based surveys could be really helpful because the populations most affected by the self-injurious this problem are very likely to use social media a lot, and it will increase the sample representativeness. And also, besides the qualitative study for the studies, other studies, including the pilot intervention studies for including the randomized controlled trials, it may be also helpful to including people with a lived experience when we design those studies. And also, one last point is that it may help also increase the buy-in of the providers into harm reduction approaches when they were able to see the unique experiences of people who have the lived experiences. Okay, so here are some resources that provides additional information and programs about harm reduction. And that's all we have. And we really now it's time for questions. And we also want to hear from everyone here about your experiences with harm reduction approaches as a provider. In what way are the harm reduction being implemented in your department where you are working at right now?
Thank you very much. There's a question in the chat about resources, so maybe if you could go back on that slide and leave it up.
Absolutely. Sure.
Questions in the room? Yes?
Thank you so much. I mean, this is really amazing presentation. It cuts to the core of, I'm an addiction psychiatrist, and it's really the way of the philosophy of how I was trained, and a lot of people in the field are trained. But I'm also very appreciative that you at least included a non-substance use related application. And I argue that, harm reduction could also be widened up to be a philosophy for life. I mean, from Buddhism to existentialism, our existence or being in the world is a harmful condition. It's full of suffering. And when we apply that to ourselves and to other people, it really helps guide what we do, the interventions we do. I mean, let's not kid ourselves. I mean, the pills we prescribe our patients, our antidepressants, our antipsychotics, are full of harm, and we're always weighing in risks and benefits. So that is a harm reduction approach. We're not puritanical that way. We're not saying, we're going to avoid psychotherapy. The best of therapeutic approaches do leave harm. Even, I've heard my fair share of cases, and I've been in situations where I see that even good therapy or a good therapeutic alliance could leave harm. The best of therapy, when it ends with termination, it leaves harm. I have my fair share of patients who had been really scarred by a very good, well-terminated psychotherapy. What I'm trying to say here is harm reduction is really something that cuts through a lot of what we do and the way we counsel people. And so that's one reflection I had. The other one is I really want to invite people and audience to reflect on how they felt when Dr. Wilkinson and Dr. Yu presented us with the harm reduction techniques, the cheat sheet. I always sit in with even a minimum level of uncomfortableness or feeling uncomfortable when these harm reduction approaches are presented, especially for the public. I know we're providers, but I invite us all to kind of look back at this sheet and see how we think about this, because there is a high level of pushback against harm reduction even until today. This is not going anyway, and that push comes from the puritanical abstinence model, and inside each one of us, I do argue, including myself, we do have this pull from our religious backgrounds, from the cultures where we were raised, where we were told to avoid risk. That's kind of my inclination. I have a little girl, and I think when she grows up, I'll have the inclination to tell her, no, don't try drugs. Even though maybe, I don't know, maybe when she's 18, I will light a joint with her and smoke it. I don't know, Anyway, I would rather she does that in front of me or with me rather than behind my back. But again, these are really, like telling bunch of psychiatrists, if you go on a shroom trip, make sure you have a sober person. This is not a very comfortable topic we talk about, and I really want us all to reflect on that. I think it's a very important talk. Thank you, guys. It's really amazing.
Thank you for sharing those reflections. I hear you, and I agree with you as well. I think this, like I said earlier, this is a controversial topic, but I do think it's a very important conversation too, which is why I'm usually a little bit more willing to facilitate the conversation. But yes, at the end of the day, right, I'm probably not going to go up to my future daughter and be like, all right, kiddo, like if you're going to do crack, like let's do it safely. However, when we're working with our patients or, trying to mitigate levels of risk, of course, in other contexts, I do think it's an important conversation to have, and like how we can better someone's life while also taking into account, what their values are, what they're looking to accomplish. Abstinence is always, the best option. However, not everyone's kind of at that point in time. So just trying to find creative ways to kind of supplement that. But thank you for your comments. I appreciate it.
Anton?
Thank you so much for this very important topic and presenting on it. And I think having this discussion with other professionals is really important, because we're not free from the stigma, even within psychiatry and medicine as a whole. I would just like to gently perhaps question or push back on the idea that MAT also counts as harm reduction. Perhaps this is just my own simplistic view of harm reduction, and that I think more of it as, okay, if you will like to continue getting high, let's find a better way or a safer way to do so. But I'm thinking of things such as methadone or buprenorphine. Those are really designed to prevent someone from going into withdrawal or into the negative effects of not having the substance on board. And it's a way to kind of stay away from the substance. People can technically take buprenorphine to get high, but generally speaking, when we're prescribing someone, that is so that they can stay away from things like fentanyl or heroin. We're not saying instead of fentanyl or heroin, do buprenorphine. But overall, I agree with almost everything that's been said, and I think it's a really good topic. So thank you for the presentation.
Yeah, thank you. And I agree in terms of the medication-assisted treatments. I don't think it's necessarily like a bulletproof technique, right, into ensuring that, the goal is going to be met. But I think it does give people opportunity to be like, okay, if I want to try and avoid this a class of substance, or, you know, I'm feeling like I'm having a really hard time being abstinent from X, Y, or Z, sometimes it'll give people like that extra layer of protection.
All right, we have what, do you have a question? Go ahead.
I was gonna say, I think this is obviously very important, and I was gonna encourage, like, I think part of my med school training was that we were all like had a harm reduction kind of session where literally looked up like how to inject heroin, and there's like up from a harm reduction website, and if you don't know how to inject heroin or fentanyl, you should look it up so that when you ask questions, you're relating to the patient and they know that you've done your research. So that was like a discussion point. And then I also wanted to say, I don't know how many years back, some economic professor had won like the Nobel Prize for the impact of like the financial impact of climate change. And I wonder if, you know, money talks. So in this case, like, is there an argument for like how much money you save a hospital system by kind of putting a needle exchange program in a community or having harm reduction practices, because that's what's going to move a systemic change.
Yeah, absolutely. I agree totally. I mean, I think particularly in, you know, our culture and in this country, you know, money does talk. And if we want to see, you know, the needle moved, we kind of have to back our, you know, research or our science in something that will be, you know, helpful to the community, such as, you know, saving money. I mean, off the top of my head, and just in terms of like some of the research we did for here, I don't have a study in mind that necessarily looks at like the cost benefits, but I would like to assume that there's at least some study out there, or at least research that's being done to help conduct that. Because I know right now in terms of like administration, there's some questions on whether or not these programs and interventions are kind of worthwhile. Yeah.
We know that injection sites do save lives, but ultimately they have devastated in Canada. We have research, you know, that has, you know, but we right now in this climate, I don't know.
I know. It's not the best.
Oh, let me just say something. Dr. Goodness online said that an email went out from the medical group on February 18th for how to obtain a harm reduction kit, Narcan, fentanyl, testing strip, breathing mask, etc. It's another good resource available to residents of Massachusetts. She put some sort of link in the chat.
Wonderful.
Got one?
Thank you, Dr. Goodness.
Thanks for this talk. It was fantastic. And one of the things that is I was struck by reading all the quotes is that patients have very different views on not just harm reduction models, but also where it comes from and when it happens, based on a lot of these quotes. And I'm wondering if one of the things that might make harm reduction techniques more acceptable by the scientific community, because there's so much that we do that's harm reductive, is to actually be very specific in some of the research in terms of where and how we implement these things. It strikes me with some of your data, a lot of the public health approaches in terms of needle exchanges and things like that were very effective. If I look at the self-harm stuff, you know, what people said, there were a few that were positive. And we also know there's a contagion effect, especially with young people in certain things. And I suspect that is what some people are even worried about. We see that with suicide and clusters of suicides, and that a public health approach like, here's how you cut if you want to cut safely, may not go very well for a lot of reasons. It may not be a specific harm reduction model. So one of the, I guess, strategies from a research standpoint might be to actually break these things down into different protocols and different types of things to really demonstrate that cost effectiveness and other things that may be really useful. And to that end, the question that I'll end with is the data that you showed about Malaysia and Australia and the US in terms of harm reduction. Do you know what they were specifically talking about in terms of obviously it was overdose death, but what methods were they talking about in particular in implementing in those different countries? Because I imagine they may have been different.
So for this study in particular, go back to it. So this one in particular did have to do with like contracting HIV and like what was I saying? The likelihood of people spreading infectious disease as opposed to overdose. So I think if I'm answering your question accurately, this more so had to do with, how harm reduction was like implemented into society, how it was accepted by different cultures, and then in turn, how they implemented these interventions into communities to prevent, the higher likelihood of HIV being spread amongst others. I'm not sure if that answered it, excuse me.
There's a question online, or what are your thoughts regarding overdose prevention centers?
What was that?
What are your thoughts regarding overdose prevention centers? If you know what that is, because I don't.
Yeah.
What's that? Oh, safe injection sites. Okay, well,
There's safe injection sites, and then I don't think in the state of Massachusetts, but I know in other states that there are like drop-in centers or places where people can go to use substances and be like supervised essentially. I mean, I think when we look at it, at surface level, there's obviously like a lot of concerns because, when we were talking about the misconceptions or like even just like the fears we have related to like substance use and other like really scary maladaptive behaviors, we never want to see people doing these things. We never want to kind of have that in our face, let's say. However, I feel like having access to those things and providing people with information and education on those will reduce the likelihood of someone experiencing significant injury or death. So I think in big picture, I would agree with having these services or agree to people having access to them, but I would understand why it's not like universally accepted by everyone.
And I think it's always a continuum of different treatment. It's not always just like safe injection center only. And harm reduction model is not a way like we're at this extreme and next extreme, like the other extreme is abstinence only model. It's like all combined. I think it's really important to really tailor those treatment based on each individual. And just want to quote Dr. Malat. Did I pronounce it right? His article introduced harm reduction approaches in the United States, and the title of that article says "Come as you are." I think that really says a lot about thinking about harm reduction, different approaches. There's a way to meet where people are, but it's never like we just have this. So.
all right, we have time for one last question, comment.
I just want to say something about the safe injection sites, because this is a really important question. Do you know what the rate of overdoses in the pilot safe injection sites that were done globally? 0%. Zero. So people do not overdose. And as you said, Dr. Yu, that's the point. You come, you use clean needles, you use your own stuff, test it, you have ability to test it. But most importantly, when you walk out, you check in with a nurse who is going to talk to you about treatment. Hey, there are these treatments. Have you thought about that? Motivationally interviewing you or engaging you into treatment. That's the most important point of safe injection sites. Thank you.
Dr. Banerjee put in the chat that Worcester was considering one, but location was an issue. But, well, it's 1 o'clock. Thank you very much. It was very interesting.
I don't think I answered that guy's question. What did I answer?